Hello, I'm Dr. Magni Humso, an internal medicine physician in Boise, Idaho. The purpose of this video is to provide an overview of the Idaho Prescription Monitoring Program and Opioid Prescribing Guidelines. Today, we will give you an overview of the opioid situation here in Idaho, explain how you can use the PMP in your daily practice, and conclude by sharing helpful information on best practices when prescribing opioids to patients. After completing this course, you'll be able to describe the opioid epidemic within the state of Idaho, integrate PMP use into provider clinic workflows, create and interpret PMP data reports, utilize patient prescription history to inform clinical decision-making, identify warning signs of medication misuse, and discuss safe prescribing of opioids and alternative treatments for pain. At the end of the video, you'll also have an opportunity to take an exam to earn continuing education credits. So let's take a look at the current situation and how opioids are impacting us.
The United States is in the midst of an opioid epidemic that began in the 1990s, fueled in part by a dramatic increase in opioid prescribing. Despite national attention, the epidemic shows no sign of slowing. This graph illustrates the trend. The age-adjusted drug overdose death rate increased on average 10% per year from 1999 to 2006, 3% per year from 2006 to 2014, and by a full 18% per year from 2014 to 2016. Rates are significantly higher for males than females. In Idaho, the drug overdose death rate is lower than the U.S. average, 15.2 per 100,000 standard population, compared to 19.8 nationwide. But we still have a serious problem here in our state. The number of drug poisoning deaths, equivalent to drug overdoses, increased steadily from 2004 to 2016, with a slight decrease seen in 2017. In 2017, about half of the 241 drug overdose deaths involved an opioid. This percentage is probably an underestimate, as 42 of the drug overdose deaths had no specific drug identified on the death certificate. So what types of opioids are causing all these deaths? The trends by type of opioid involved in overdose deaths have been described as three distinct waves starting in 1999. Initially, there was a steady increase in deaths involving prescription opioids. A second wave began in 2010, with increases in overdose deaths involving heroin. The third wave began in 2013, with a rapid rise in deaths involving synthetic opioids, including illicitly manufactured fentanyl. In 2016, the number of deaths involving synthetic opioids surpassed those involving heroin and commonly prescribed opioids. CDC analysis of retail prescription data shows that the opioid prescribing rates in the U.S. peaked in 2012 at 81.3 per 100 persons. The rate decreased annually from 2012 through 2016 to a rate of 66.5 per 100 persons. At 77.6 opioid prescriptions per 100 persons, the prescribing rate in Idaho is higher than the national average of 66.5. A prescription drug monitoring program, or PDMP, is one tool that can help healthcare providers promote safe and appropriate use of prescription opioids. A PDMP enables healthcare providers to review a patient's prescription history to inform their own prescribing decisions. PDMPs are especially helpful for identifying patients getting opioids from multiple prescribers, those receiving high total daily dosages, plus patients receiving concurrent benzodiazepine and opioid prescriptions, all of which are risk factors for overdose. Idaho's Prescription Drug Monitoring Program is named the Idaho Prescription Monitoring Program, or Idaho PMP. For the purpose of this video, we will use PMP when we refer to the Idaho Prescription Monitoring Program. The Idaho Prescription Monitoring Program is part of a comprehensive approach to combating the opioid crisis. The Idaho PMP is a statewide electronic database which collects, stores, and maintains information on all Schedule 2 through 5 controlled substances that are dispensed in our state or shipped from a mail service pharmacy to an Idaho resident. As of July 1, 2018, information on the dispensing of opioid antagonists such as naloxone is also maintained in the PMP. How up-to-date is the data? Specified data on controlled substances must be reported by the end of the next business day by all entities dispensing controlled substances within or into Idaho. This includes drug outlets and prescribers that dispense controlled substances to humans. Data on controlled substance prescription drug samples, however, does not need to be reported. Healthcare providers and other authorized individuals may request information through a secure website, as we will review momentarily. At present, all 50 states, the District of Columbia, and Guam have operational prescription drug monitoring programs. Now for a brief history of the Idaho PMP. In 1997, the Idaho Board of Pharmacy was granted authority to establish the Prescription Monitoring Program. The Idaho Board of Pharmacy gives authorized prescribers, dispensers, and their delegates access to the Idaho PMP so they can look up, view, and print controlled substance prescription reports on their patients. Out-of-state prescribers and pharmacists can also request access to the Idaho PMP. The Idaho Board of Pharmacy is currently connected with PMPs in 24 other states through PMP Interconnect. This includes the neighboring states of Montana, Nevada, Oregon, and Utah. The PMP Interconnect allows practitioners to query other states' PMP data through the Idaho PMP website. In a minute, we will show you how to find a list of these states within the Idaho PMP. Now we will learn more about the Idaho PMP. The Idaho Prescription Monitoring Program allows PMP-registered practitioners and pharmacists to have up to 4 delegates that can run patient reports for them. The delegate can be a nurse, medical or office assistant, or current student of a health profession if a licensed practitioner or registered graduate of that profession may access the database. Additionally, a delegate can be a registered pharmacy technician who is designated by a supervising practitioner or pharmacist to access the database. Delegates can access the database under the practitioner or pharmacist's supervision. Each must have their own account and not share the login information with anyone else. Prescribers and pharmacists are considered supervisors and are responsible for the actions taken by their delegates. The Idaho Board of Pharmacy's Prescription Monitoring Program webpage has more information on the delegate registration process. The Idaho Board of Pharmacy grants access to the Idaho Prescription Monitoring Program website to authorized prescribers and dispensers and their delegates so that they may look up, view, and print controlled substance prescription reports on their patients. To log into your account, go to the PMP Aware login and enter your email address plus the password you used to create the account. There is also software available that allows a user to access the patient report directly through their own electronic medical record. When using this software, the user does not have to log in to the PMP or create a patient report in order to see their patient's prescription history. You can contact the Board of Pharmacy for details. The patient request is a report containing prescription drug activity for a specific patient. It can be accessed by logging into the PMP and clicking on Menu, RX Search, Patient Request. Next, you'll see search fields for looking up the patient's record. All fields with a red asterisk are required. At a minimum, you must enter the patient's first name, last name, date of birth, plus the starting and ending dates for the search period. It's important to know that the name in the database will reflect how the name was entered by the pharmacist when the prescription information was filed with the PMP. A patient may have more than one record if they have been entered into the database using different names. The partial spelling boxes are helpful when you need to search for a patient using only a portion of their name, or when searching for hyphenated or abbreviated names. This feature requires at least 2 letters for each name. Delegates requesting a patient report must select a supervisor. As we discussed earlier, Idaho and multiple other states have agreed to share PMP data. If you want to get patient information from another state, you can do that here, but only exact name matches will work. If a state is not shown on the list, then information is currently not available from that state. When a patient has been identified, results are returned to the screen. If there are multiple patients in the result, you can refine your search and rerun the report. Or you can select one or more of the patient groups shown and run the report on them. The patient report has 4 main sections: patient information, prescriptions, prescribers, and dispensers. The patient information section shows the criteria used to search for the patient. It will also display all known patient names, birth dates, and addresses matched to the individual you searched for. The prescriptions section lists information related to each prescription dispensed to the patient within the search period entered. The ID column links a specific prescription to a specific name and address used at the time the prescription was filled. The dispensers section displays all dispensers who filled a prescription to the patient within the search period. Information on the screen can be collapsed, expanded, resorted, or resized as needed. Depending on the account type, you can also download the report as a PDF or CSV file. The Idaho Board of Pharmacy may release unsolicited information to pharmacists and practitioners when the information could assist in preventing or avoiding inappropriate use of controlled substances. Reports are automatically generated and sent to practitioners when threshold numbers of prescribers and pharmacies have been reached or exceeded by a patient during a given month. In Idaho, this threshold is when a patient has received controlled substances from 5 or more different providers in a calendar month. In these cases, a notice of the unsolicited report is emailed to the providers and pharmacists involved. These unsolicited reports offer many benefits. This includes providing information regarding controlled substance prescriptions the patient may already be receiving. The reports also provide warnings about patients who may be misusing or diverting controlled prescription drugs and can assist prescribers in coordination of care. Plus, they enable more informed prescribing. If you have any questions regarding the Idaho Prescription Monitoring Program, you can visit this website or email us at this address. So, when should you check the PMP? In some states, you must check prior to writing any opioid prescription. In Idaho, while it is not mandated, we do encourage you to check first as well. When opioids are used to treat chronic pain, the CDC recommends checking the PMP before starting therapy and at least once every 3 months thereafter. The PMP can help you identify patients obtaining opioids from multiple providers, calculate the total amount of opioids prescribed to the patient per day, and find patients who may be on high-risk combinations of medications. The PMP can also help you verify that the medications filled match the prescription that was written. So what should you do with the information you find in the PMP, particularly if that information is concerning? Be sure to confirm that the information in the PMP is correct. Don't dismiss patients from care based strictly on information you find there. Instead, use the information as an opportunity to talk about drug safety and potentially life-saving intervention. When it comes to patients on high doses of opioids, most experts agree that 50 morphine milligram equivalents, or MMEs, or more per day increases the risk of an overdose without a corresponding increase in pain control. For patients whose dose of opioids is 50 MMEs per day or more, consider talking to them about tapering slowly to a safer dose. You should also offer naloxone to any patient taking 50 MMEs per day or more. Also, talk about risks for respiratory depression and overdose. Whenever possible, avoid prescribing opioids and benzodiazepines concurrently, as the combination is associated with an increased risk of overdose death compared to opioids alone. You may want to coordinate with a patient's mental health professionals or other prescribers. You should also be aware that other central nervous system depressants, like muscle relaxants and hypnotics, can also potentiate the CNS depression associated with opioids. For those receiving prescriptions from multiple providers, we suggest you carefully counsel the patient about the risk of overdose and coordinate care with their other prescribers. Some PMP findings may raise concerns about a substance use disorder. Discuss these with the patient and arrange treatment, typically a combination of medication and behavioral therapies. The Idaho Care Line 211 may help you find treatment resources in your community. If diversion is suspected, consider urine drug testing to help determine if opioids can be discontinued without causing withdrawal. Now let's discuss how to recognize the warning signs of medication misuse. As a healthcare practitioner, you have a responsibility to ensure controlled substances are prescribed solely for a genuine medical need. You must also prescribe them appropriately to safeguard against abuse and diversion into an illegal market. You should also recognize the warning signs of potential medication misuse. While there's no uniform way to identify medication misuse, there are some common signs you may see. Look for an assertive personality, an unusual knowledge of controlled substances, textbook answers to questions about medical history, or vague answers, lack of a regular doctor and often health insurance, requests for a specific drug and a reluctance to try a different drug, no interest in diagnosis, failure to keep appointments, especially for diagnostic tests or consultations with another practitioner, refusing permission to attain past records, an insistence on being seen right away or making appointments for the end of the business day, calling or coming in after regular business hours, contending that specific non-opioids do not work or that they are allergic to them, claims of being a patient of a practitioner that is not currently available, saying that the prescription has been lost and needs to be replaced, and finally, multiple unexplained dose escalations or non-adherence to treatment plans. Despite these concerns, remember that patients misusing medications may have a legitimate medical need or possibly an underlying substance use disorder. In both cases, they should be evaluated and treated appropriately. It's also important to keep in mind that not all patients who misuse medications are strangers. They may also be a close friend, relative, neighbor, or a longtime patient. In September 2017, the Idaho Board of Medicine adopted a policy for the use of opioid analgesics in the treatment of chronic pain. The policy outlines guidelines for evaluating a physician's pain management protocols, including the prescribing of opioid analgesics. If you would like to learn more about this policy, please visit the Idaho Board of Medicine website.
We hope you now have an understanding of how the PMP operates and how you and your patients can benefit from using this tool. Now I want to discuss prescribing opioids for pain relief, how to determine when to begin or continue using opioids for chronic pain, opioid selection, dosage, and duration, as well as how to assess the potential risks and harms of using opioids. Chronic pain is pain that lasts over 3 months or past the time of normal tissue healing. A lot of Americans, at least 11%, experience daily chronic pain. And opioids are frequently prescribed for chronic pain. And primary care providers are often those who treat chronic pain. And actually, we are responsible for the majority of opioid pain medications that are prescribed in the United States. That said, evidence shows that providers in general are uncomfortable prescribing opioids and don't feel that they have sufficient training. We write a lot of prescriptions. In 2012, healthcare providers wrote 259 million prescriptions for opioid pain medication, enough for every adult in the United States to have a bottle of pills. The amount of opioids we prescribed have quadrupled, but the amount of pain that Americans report remains unchanged. This is a study that compared the number of milligrams of opioids that were prescribed per 100,000 population, that's on the x-axis, to the rate of death per 100,000 population. So basically they compared death rates to prescription rates of opioids, and they were able to show that as prescriptions increased, the number of grams in the population increased, the death rate went up. And this is state by state data, and you can really see that straight line. The more medication out there, the higher the risk of death. We know that the risk of having an overdose goes up if you receive prescriptions from multiple different sources. And that makes sense. Oftentimes people who receive prescriptions from multiple different pharmacies or prescribers are on higher doses of morphine equivalents, and they are at higher risk of overdose. And this is why the CDC decided to convene a group of experts to come up with a set of guidelines to help prescribing practices. They brought together primary care providers primarily who had experience with chronic pain management, and also involved experts in the field and different agencies. This group out of the CDC asked 5 key questions. Question 1, what is the effectiveness of long-term opioid therapy? Question 2, what are the risks of opioids? 3, what is the effectiveness of different dosing strategies? 4, are there any instruments or calculators out there that can help us predict the risk of having an overdose or developing consequences of using opioids? And question 5, what is the risk of that initial prescription for acute pain in terms of being on opioids for a long time? We'll go into the data and the specific recommendations in detail, but quickly the general answers to these questions was there is no long-term data really about the effectiveness of opioids for chronic pain. Most of the studies have lasted less than 6 weeks. We know that a lot of patients in primary care struggle with opioid use disorder, and the prevalence, there's a wide range based on the study, but from 3% to 26%. And we do know that the higher the dose, the higher the risk of developing consequences, such as an overdose. There are inconsistent results for different dosing protocols, but in general, what we do know is that long-acting and extended relief medications increase the risk of overdose, and we really should avoid these medications. We know that methadone is one of the highest risk medications, and what we also know is that increases in doses of opioid pain medications does not mean that people have better function or better pain control. The 4th question was about the accuracy of instruments for predicting risk, and in general, they are not really good at figuring out who is truly at risk, so we cannot use them to make decisions about who is safe for taking opioids. Finally, the last question was about the effect of prescribing opioids for acute pain, and there is an increased likelihood of long-term use when you're given that initial prescription. The CDC group came up with 12 key recommendations for prescribing chronic pain medications, and they're divided into 3 main areas: determining when to initiate or continue opioids for chronic pain, opioid selection, dosage, duration, follow-up, and discontinuation, and finally assessing risk and addressing harms of opioid use. So let's start with this first group. Recommendation number 1, opioids are not first-line or routine therapy for chronic pain. Non-pharmacologic therapy and non-opioid pharmacologic therapy are preferred. We should consider opioid therapy only when the benefits are expected to outweigh the risks, and that's benefits both in terms of pain and function. And if we're using opioids, they should not be used alone, but in conjunction with non-pharmacologic therapies and non-opioid pharmacologic therapy. There are many different options in terms of non-opioid pharmacologic therapy. We have acetaminophen, there's NSAIDs. We know that for acute back pain, for example, NSAID are as effective or better than NSAIDs, even when it's combined with muscle relaxers or hydrocodone, acetaminophen. We can use muscle relaxers, gabapentinoids such as gabapentin or pregabalin. can be beneficial, especially if there's neuropathic pain. SNRIs such as duloxetine or venlafaxine, as well as TCAs such as amitriptyline, can help chronic pain. Again, it is of course difficult, but these are options that can truly help patients. There are different things that you can do in terms of non-medication therapy, obviously ice and heat, hot baths and showers, physical therapy. That is probably what works the best for chronic low back pain. Pool therapy, yoga, there's new studies of yoga suggesting that it could be the same as physical therapy in some populations. Mindfulness-based stress reduction can help, and of course cognitive behavioral therapy. So the second recommendation was really to establish goals prior to starting someone on opioid therapy, meaning there should be realistic treatment goals both for pain and function, and there should be a plan in place for stopping the therapy if either there are side effects or these goals are not reached. And again, the medication should only be continued if there really is clinically meaningful improvement in both pain and function that outweigh risks to patient safety. The third recommendation is to discuss risks and benefits with patients before starting treatment. This is something that most of us probably already do, but we might not be as focused as doing this with patients who are initially prescribed opioids for acute pain. The second section of the CDC chronic pain guidelines goes over opioid selection, dosage, duration, follow-up, and discontinuation. The fourth CDC recommendation emphasizes the importance of prescribing short-acting opioids when clinicians initially prescribe opioids for pain. As well, to stay away from methadone if possible, as well as transdermal fentanyl, and again, really avoiding combining short-acting pain medicines together with extended-release ones. There is actually data to suggest that when patients are initially prescribed long-acting pain medications, regardless of whether they're prescribed for a short period of time or long-term period of time, those patients that are prescribed at the extended-release, long-acting versions of medications are at higher risk of overdose than those who are prescribed immediate-release pain medications. The fifth recommendation, use caution at any dose and avoid increasing to high dosages. The fifth recommendation is to be careful at any dose and to make sure that you use a lot of caution when you're going up on the dose. When opioids are started, again, you start at the lowest dose possible, and especially when you're getting up into doses above 50 morphine milligram equivalents a day, you have to use extreme caution and definitely talk with your patients about the risks. This was a study published in the Annals of Internal Medicine in 2010. It was actually done out of the state of Washington at Group Health Cooperative. And they looked at their patients who were prescribed opioids for non-cancer pain, and they compared those folks who were prescribed low doses, meaning 1 to 20 milligrams of morphine a day, to those who were prescribed higher doses, up to over 100 milligrams of morphine per day. And they showed that there was a much higher risk of overdose if you were prescribed higher doses of morphine. So you can see on this graph that if you're moving into 50 to 100 milligrams per day of morphine, you have almost 3 times the risk of an overdose. And if you're on over 100 milligrams of morphine per day, your risk of an overdose is almost 12 times that of someone who's on a much lower dose. There's a great CDC opioid prescribing guideline mobile app. It includes all of the CDC recommendations, and it also includes a calculator for how to calculate morphine equivalents. Basically, it allows you to put in the opioid that that patient is on and have the calculator to convert it to morphine milligram equivalents. This again can just help you assess their risk of overdose based on the dose that they're on. So the sixth recommendation is to prescribe no more opioid than needed for that first episode of acute pain, because we're learning that long-term opioid use often begins with the treatment of that initial acute pain episode. This recommendation was initially based on expert opinion alone, and they emphasized that 3 days will often be sufficient for that initial episode. Since then, we've acquired a decent amount of data to suggest that this does pan out, and we really should be limiting those initial prescriptions to 3 days or less. This was a study published in the Morbidity and Mortality Weekly Report in 2017 that looked at a commercially insured population and their risk of being on an opioid a year later and 3 years later based on that first initial prescription and how many days that initial prescription was for. So you can see on the x-axis, you have the number of days supply of that first opioid prescription. On the y-axis is your probability of continuing to use opioid pain medications. The solid line is at 1 year and the dashed line is at 3 years. And you can see that the bigger that initial prescription, the higher the probability of you still being on chronic pain medications a year later and even 3 years later. And we talk about 3 days. 3 days makes a lot of sense because you can see even at 3 days there's increased risk, and you're actually have an over 5% probability or chance of still being on opioids a year later. Another way to look at this is based on the number of refills you obtain for that initial prescription of opioid pain medication. And it makes sense, the more prescriptions you received for that initial pain event, the higher your chance of being on opioids a year later and 3 years later. In 2017 in the New England Journal, a study was published that looked at differences in emergency room physician prescribing patterns in terms of opioids and the risk that their patients were going to be prescribed an initial opioid medication and their risk of being on opioids a year later, or long-term opioids. They basically looked at physicians within different ERs, and they labeled them either as a low prescriber, so somebody in the first quartile was a low prescriber versus a high prescriber in the third or fourth quartile. So the top graph shows that if you happen to go to the ER on a day when a high prescriber was working, regardless of what you needed pain medication for, you were more likely to receive an opioid pain medication if the prescriber fell into the highest quartile. So you can see among the highest prescribers in quartile 4, over 20% of patients received a pain medication for a particular indication. While if a lower quartile prescriber, someone who doesn't tend to use opioid pain medication, your chance of getting an opioid pain medication was closer to 5%. Again, that did not have to do with that particular patient's complaint. It had only to do with that particular physician's practice patterns. We have an enormous impact on whether or not a patient receives a pain medication. If you look at the bottom figure, you can see that just like that initial event, if you go to the ER when there's a high prescriber there, you're more likely to get a pain medication. You're also more likely to be on a pain medication long term if you happen to go to the ER on a day when somebody who prescribes a lot of pain medications is working. Just like there's a lot of variation among ER physician practices, there's also a lot of variation among orthopedics practices. This was a study just done at a single hospital system in New Hampshire, just a cross-sectional study done in 2015, and they looked internally at what happened for their patients after they had a total hip replacement, a total knee replacement, or carpal tunnel repair, so standard orthopedic procedures. On average, patients received 90 pain pills after a total hip replacement, a similar number after a total knee replacement, and less after a carpal tunnel release. But there was enormous range. The range after a total hip replacement was from 20 to 330 pills. And after a total knee replacement, 10 to 200 pills. Again, this was an observational study. We don't know exactly why there was that variability, but it seems that a lot of it has to do with that orthopedic physician practice pattern. And what's also important is that a lot of patients had leftover unused opioid pain medication. They actually reached out to patients to find out whether or not they'd used up all of their medications. And in 61% of cases, they had leftover pain pills. And less than 50%, so less than 1 in 2, actually disposed of those pain pills properly. And that's, of course, a risk, having leftover pain medications in a home that other individuals, especially kids, could get hold of. And they summarized in that article that during that study year, out of that single hospital system, over 43,000 unused extra opioid pain pills were prescribed. So again, we have a lot of room for improvement in just standardizing practices, because what patients experience depends a lot on who did their surgery, who they saw in the ER, who was their primary care physician. There's also a lot of variation among dentists and their prescribing patterns. This was a study just looking at claims data for opioid prescriptions for Medicare beneficiaries. And they basically showed that there was an enormous amount of variation across the country in terms of the number of days of opioid medication prescribed by dentists for a variety of procedures. And you can see in this map, in light blue, it's 2.9 to 3 days per prescription. In the dark blue at the bottom, you have 4.3 to 4.4 days per prescription. And again, you can see that depending upon what state you are in, you're more or less likely to get more or less opioid pain medication after a procedure. And again, this variation doesn't seem like a lot, but there was actually a very wide range. Patients received opioid pain medications for as little as 1 day to 168 days from that initial prescription. So again, there's a lot of room to standardize care. There's no reason why there should be such a big variation in prescriptions that patients receive, and that there should be such regional variation. The 7th CDC recommendation is to offer a taper if opioids cause harm or are not helping. Again, we should be evaluating benefits and harms with patients 1 to 4 weeks after starting opioid therapy for chronic pain, and of course, anytime there is a dose increase. And every 3 months, we should really be reevaluating whether or not we're reaching the goals that we had previously set when somebody's on pain medication. And if the benefits do not outweigh the harms, then it's time to work with patients and go down on the dose. This is, of course, easier said than done. Really, we're not recommending that everybody's tapered or folks are tapered quickly. We want people to stay in care and hopefully do this together so that we can get patients to a safer level. If you're tapering patients, it's reasonable to start with 10% per week, but again, some patients will do a lot better with much slower tapers. If there's a safety concern, of course, then we taper quickly. It makes sense to get additional expertise when a patient is pregnant because of potential risks to the developing fetus and induction of labor if patients go through withdrawal. It is, of course, important to work with patients and provide support and add other non-pharmacologic and pharmacologic therapies. They can experience hyperalgesia immediately after tapering. However, studies and clinical experience suggest that most patients do report improved function without worse pain after tapering opioids. The 3rd section of the CDC guidelines is assessing risk and addressing harms of opioid use. The 8th recommendation from the CDC is to evaluate and address risks for opioid-related harms. Talking with patients about the risk of an overdose, co-prescribing naloxone for reversal of an opioid overdose, talking with patients about their risks, especially if they have a history of substance use disorder, if they are on higher doses, if they've had an overdose in the past, and if they are on concurrent benzodiazepines. This was a study published in the Annals of Internal Medicine in 2016 that looked at a commercially insured population on chronic opioid pain medications. And they were interested in seeing what happened to patients after they had an overdose event. So on the x-axis, you can see is time. Time 0 is when they had their overdose event. They looked at patients who had at least been on 60 days of pain medications before the opioid overdose event, and then they followed them for about 2 years or so. On the y-axis, you have patients in dosage categories. So that's the percentage of patients that were receiving certain amounts of pain medication. In green on the top, you have folks on large doses of pain medications, over 100 morphine equivalents per day. In red, you have patients on moderate doses, so 50 to 100 milligrams of morphine a day. And in blue, you have patients on low doses of opioids, less than 50 milligrams per day. You can see that even after patients had an overdose event, the majority remained on opioids afterwards. In fact, 90% stayed on opioids afterwards. Some had a decrease in their dose, but they did stay on it. And what they showed in this study was that Among the patients who were on large doses of opioids, 17% had another opioid overdose event within 2 years. Among the folks on moderate doses, 15% had another overdose within 2 years. So again, you can't necessarily say that somebody needs to be tapered immediately or get off opioids after an overdose event. Those can happen for many different reasons. However, it is a very high-risk situation, that initial event, but also the risk of having another overdose. And it is important to work with these patients to hopefully get onto lower doses, and of course also making sure that they have access to naloxone for reversal of opioid overdose. It's of course important to assess patients for mental health comorbidities. Psychological distress frequently interferes with improvement of pain and functions in patients with chronic pain. Using validated instruments such as the GAD-7 or the PHQ-9 to assess for anxiety and depression is useful. Treatment for depression can improve pain symptoms and might decrease somebody's overdose risk. Just like we should be assessing for mental illness, we should also be assessing for substance use disorder. It's important to ask patients regularly about their drug and alcohol use. There are single screening questions that can be used, such as how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons. There are also other valid screening tools. It's also important to regularly check the PMP, like we talked about earlier, and to do regular urine drug testing to assess for concurrent substance use. This is just a reminder to co-prescribe naloxone for reversal of opioid overdose. There are great places for more CME on that. The Office of Drug Policy here in Idaho has a great brochure that they're willing to send you and that you can have in your offices. I typically prescribe naloxone, talk about the basics of how the medicine works and how to administer it, and then give them this brochure to keep with their medication. The 9th CDC recommendation is to check the Prescription Monitoring Program regularly before you prescribe and also regularly, ideally every 3 months, and I actually would recommend checking it every time that you prescribe an opioid pain medication. It's important because the risk of an overdose goes up if someone is receiving pain medication from multiple sources. It can also help clue you in if diversion might be happening. If you find concerning information in the prescription monitoring program, it does not mean that somebody needs to be discharged from your practice immediately. It's an opportunity to talk with that patient about the risk of an overdose. It's an opportunity to try to figure out if there is actually an opioid use disorder here and try to get them into formal treatment for that. The 10th CDC recommendation is to regularly test urine drug screens, at least annually, but perhaps more often, both to make sure that the patient is taking the medication that you have prescribed, also to find out about other substance use that they might not have disclosed, again, to make sure that you can provide them with the care that they need. The 11th recommendation from the CDC Chronic Pain Guidelines is to avoid prescribing opioid pain medications together with benzodiazepines. The two together just really increase your risk of an overdose. There's always exceptions to every rule, but as much as possible to avoid this combination. And the 12th recommendation from the CDC guideline is to make sure that you are offering evidence-based treatment, either yourself or refer to someone who does for patients with opioid use disorder. It can be difficult to tease out the overlap between chronic pain and need for opioids versus chronic pain and actually an opioid use disorder. But there are experts who can help you with this, and again, it's very important that if somebody does have an opioid use disorder that they are referred to treatment, and this really should be medication-assisted treatment with buprenorphine or methadone together with behavioral therapies. If you're interested in learning how to prescribe buprenorphine and incorporate that into your practice, SAMHSA has a list of places where you can obtain the training, and it's actually even possible to get the training for free. This concludes the section on the CDC guidelines for prescribing opioids for chronic pain. We hope that you learned the importance of checking the PMP prior to writing a prescription for opioids and regularly during treatment, that you will limit the dose and duration of that initial prescription for acute pain, That when patients are on chronic opioids, that you will regularly reassess the benefits and the harms, and make sure that patients are truly reaching their goals of pain control and function. That you will think about the dose and get patients to the lowest tolerable dose, ideally less than 50 morphine equivalents per day. That you will make sure that patients are receiving alternative types of pain control as well, whether pharmacologic or non-pharmacologic. That you will co-prescribe naloxone, and that you'll make sure to refer patients for evidence-based treatment if they do have an opioid use disorder and not just chronic pain. Thank you for taking the time to learn more about the opioid epidemic in Idaho, the Idaho Prescription Monitoring Program, and the CDC Guideline for Prescribing Opioids for Chronic Pain. We hope that this training will help inform your clinical decision-making with regard to prescribing opioids for both acute and chronic pain.